Okay, let's see what we can get through. I'm trying to finish up here on the urinary elimination, and then we'll do bowel elimination also. Ooh, and I think we got to managing incontinence. So there are 6 types of urinary incontinence that we're going to go over. All right, first one being stress incontinence. Stress incontinence is when you have a loss of a small amount of urine with intra-abdominal pressure, such as which types of activities? These are going to be things like coughing, sneezing, laughing, these types of things when you have this stress incontinence. The causes are loss of perineal sphincter muscle control secondary to childbirth. So this happens very frequently to women who have recently given childbirth or who have had multiple children. Menopausal atrophy, prolapsed uterus, obesity. These are all causes for stress incontinence. All right, we've got treatments or pelvic floor strengthening exercises. These are called Kegel exercises. Weight reduction if obesity is the cause, and surgical intervention could be necessary, and that's called bladder tacking. That's what they call it. If the stress incontinence is severe, then that's kind of what they'll progress to, is a surgical intervention. All right, then we've got urge incontinence. So in urge incontinence, it's frequent perceived need to void, unable to hold the urine flow in absence of the bathroom facilities. These causes are usually bladder irritation related to infection. So if you have a severe UTI, we may have some urge incontinence where we are not making it to the bathroom in time. Loss of bladder tone, especially after a recent indwelling catheter. This happens frequently if you've had a catheter for too long, which is one of the reasons they don't like you to keep a catheter very long. Treatments are going to be restricting the fluid intake, restricted fluid intake of at least 2,000 milliliters per day, so still 2 liters, and omitting bladder irritants such as alcohol and something else we've talked a lot about, which is caffeine. And if we're going to give diuretics, we're going to try to give them in the morning. We talked about that a little bit also. We want to give any diuretics in the morning so they're not up all night having to go to the bathroom. All right. Now we've got reflex incontinence. This is the spontaneous loss of urine when the bladder is stretched with urine. So when I told you guys my story about how I had to go to the bathroom so bad on that trip that we took, and we couldn't get off of the interstate, if I had had some incontinence at that point, that would have been reflex incontinence. It would have just been spontaneous loss of urine because my bladder was stretched so full. The person automatically releases urine and can't control it. So causes can also be spinal damage to the spinal cord. This is the most common cause for reflex incontinence. There's going to be damage to the spinal cord and other neurological conditions such as stroke. And treatment for reflex incontinence is going to be intermittent catheterization and incontinence training, where they train to go to the bathroom at specific times. You can literally train your body. I don't know how many of you watch Big Bang Theory. I love that show, but Sheldon has a bathroom schedule. Everybody has to go to the bathroom on a schedule. And basically that's what this is, incontinence training. You're scheduling yourself to go to the bathroom at certain times to try to prevent having incontinence. So functional incontinence is control over urination that is lost because of inaccessibility of the toilet or compromised ability to use one, such as manipulating clothing, transferring from a wheelchair, getting assistance from staff. So truly, when I had that situation happen, it truly wouldn't have been reflex incontinence, I guess, because it really didn't have any kind of neurologic issue. It would have been more of a functional incontinence, the inaccessibility of a bathroom. Okay, but this happens a lot. I've talked to more and more people as our parents are getting older, in realizing that clothing is very difficult to find nice looking clothing for adults that don't have buttons and snaps and zippers and all this stuff. Just some nice pull up, pull down pants. But that's what they need. They need to get to the bathroom, and they don't want to have to manipulate a whole bunch of clothes. Causes are impaired mobility, restraints, impaired cognition, inability to communicate. So sometimes the patient can't tell the nurse that they have to get to the bathroom in time. Call bell not within reach. Okay. Treatments are going to be clothing that's easy to remove, easily accessible to the toilet, clear the pathway to the bathroom, and providing assistance to the toilet. All right, number 5 is total incontinence, the loss of urine without any identifiable pattern or warning. This person passes urine without the ability or effort to control. The causes here are going to be things like altered consciousness, loss of sphincter tone, urethral or vaginal fistulas. The fistula is another opening, an abnormal connection, I guess, between the urethra and the vaginal, so urethral vaginal fistulas. Treatment are going to be things, absorbent undergarments, external catheters, or indwelling catheters for the patient to use if they've got total incontinence. And number 6 is overflow incontinence. So this is when we have urine leakage because the bladder is not completely emptied or distended with retained urine. So we talked a lot about retained urine and how we would measure that, how we know if we've got retained urine. So causes for overflow incontinence are overstretched bladder, the weakened muscle tone, enlarged prostate, distended bowel. If your bowel is distended, if you actually look in your anatomy and physiology stuff, you'll see there is a very close relation there. So if your bowel is very distended, it can affect your how you're urinating. Bladder spasms can also cause overflow incontinence. And treatment is going to be proper hydration, adequate bowel elimination, and if we have a catheter in, we're going to ensure patency of the catheter. Make sure that it's free and clear of any debris. All right, so managing urinary incontinence. Perineal care is one thing we can do. So provide dry clothing and linen as soon as possible. It's very degrading for patients to have to sit there in their own urine when they didn't plan to do that, obviously. Washing the perineum with soap and warm water after each episode, rinsing and drying well. Why is that important? Okay, so hopefully you realize that that is important because urine is acidic. If it remains in contact with the skin, it's going to start causing skin breakdown. Elderly people have very fragile skin to begin with. So the longer we let them sit in this urine, the more significant skin breakdown we're going to get. Apply lotion to moisturize the skin. Use petroleum-based lubricant as a protective barrier. And antifungal creams may be prescribed to prevent fungal growth. All right, we may also need to do some continence training. So this is restoration of control of urination. It's also called bladder training. So it involves teaching mechanisms of voiding, which is scheduled voiding. So like I was talking about with Sheldon on Big Bang Theory, everybody has a schedule. You go to the bathroom at this time. It's really kind of funny. He makes his roommate have a schedule. Whether you want it or not, you've got a schedule. Assisting the client to void every so many hours. Usually it's about every 2 hours. Then as a pattern develops, the person gains better control over that. Okay, so usually during the daytime, you're taking your client to the restroom at least every 2 hours. Whether they need to go or not, they're getting up and going to the bathroom every 2 hours. That's training their body. All right. It's beneficial for clients with lower body paralysis who wish to facilitate urination without the use of catheters. All right, it's often a slow process. It requires a lot of dedication from the healthcare team, the client, and the family. The client really has to want to do this. It's not a magic fix. It's not a quick fix. It's going to take time. But if the client wants to do this, it can happen. All right, do's and don'ts. So be sure that you set realistic short-term goals. Don't discourage the limitation of oral fluids. Plan a schedule. Assist the client to void every 2 hours during the day and every 4 hours during the night. That's really important, okay? During the daytime hours, whether they need to go or not, every 2 hours you're getting them up to go. During the night, every 4 hours you're getting them up to go. Especially those clients that are wanting to be bladder trained, okay? Share all plans, schedules, goals with the client, family, and staff so everybody's on the same page. It's very consistent throughout different shifts. Teaching Crudet's maneuver. So Crudet's maneuver is the act of bending forward and applying pressure to the bladder. And you have a reference there in your book. And instruct a paralyzed client to identify any sensation that precedes voiding. So they may not feel a full bladder like what we feel, but they may have some type of sensation. And they don't recognize it unless they are specifically trying to recognize symptoms, sensations. Right, teaching the clients with stress incontinence to perform Kegel exercises, which improves the bladder's ability to retain urine. And there's nursing guidelines on page 681. Be sure that you look over those guidelines, okay? Very important. And we're also going to do lifestyle modifications. So increasing the daily intake of oral fluids, 8 to 10 glasses, or how many milliliters of fluid a day to encourage bladder flushing. So hopefully you remember what we talked about the other day. It's going to be 3,000 milliliters of fluid. You're going to limit their intake of caffeine, alcohol, artificial sweeteners, all these things that irritate the bladder. If their BMI is over 30, we're going to try to get them to lose some weight. Smoking cessation is big. Avoid constipation, because as we said, that can cause some issues with urination. And be aware that high impact exercise is associated with increased stress incontinence. I mean, that is just a fact. All right, Kegel exercises are on page 680 in your book, so be sure that you read over those. Those are pelvic floor muscle exercises, strengthening the perineal muscles. Strengthens and tones those muscles used in voluntary holdback of urine, gas, or stool. So it's recommended that you do 40 to 60 a day, dividing into 4 sets. Don't do them all at one time. Do 1 set sitting, 1 set laying down, and 1 set standing. Hold it for 10 seconds each. One thing that people sometimes tell them is to hold their urine while they're urinating to do these exercises, to hold back or prevent the from urinating. And that's how you know when you're doing the right muscles. You have to be really careful about telling patients something like that, because if they start doing this while they're urinating frequently, then we're going to get some backflow of urine. Okay, we're not going to get it all out when they're urinating, and then we're going to have more problems, cause increased risk for infection and things like that, and residual. So we're going to tell them to imagine urinating and stopping the flow of urine and tightening the rectum to keep the gas from passing. Okay, so be sure you look over that in your book. Page 680. Ask me any questions that you guys may have on Kegel exercises. All right, I'm going to move on to bowel elimination real quick. Okay, so I'm sorry this is going to be kind of a long video, but I wanted to just go ahead and combine all of these things. So we're going to go on to chapter 31, which was bowel elimination. Bowel elimination includes defecation, which is the act of expelling feces. Large intestines, water is removed from the remnants of the digestion into a consolidated mass. Then we've got peristalsis, which are the rhythmic contractions of intestinal smooth muscles. Increased peristalsis with eating is called the gastrocolic reflex. I don't want to read all of this word for word. You guys can read it in the book. I'm going to just try to hit some highlights here, okay? But please ask me any questions. You definitely want to understand these definitions, what it means, what occurs during these phases of elimination, okay? Sometimes cramping occurs as the gastrocolic reflex occurs. You'll also get the urge to defecate. And the process to defecate includes peristalsis, gastrocolic reflex, the urge to defecate, anal sphincters, and the Valsalva maneuver. Be sure that you know what all of those are. They're all in the book. The peristalsis we just talked about was that movement of pushing things through the GI tract. The gastrocolic reflex propels the stool forward, packing it in the rectum. The urge to defecate occurs as the rectum starts distending with the stool. Then we've got your anal sphincter, which is a ring-shaped band of muscles. And the Valsalva maneuver is the contraction of the pelvic and abdominal muscles to increase intra-abdominal pressure to dispel the stool. All right, here's a picture for your GI system. All right, assessment and elimination patterns. So we've got elimination patterns determine. One thing you definitely need to do is determine the client's usual patterns. How often do they normally go? How much effort is usually required? Do they require any elimination aids at home? Do they do laxative, stool softener, anything like that? Not everybody goes once a day. Some people go 6 times a day. Some people go once every other day. So you need to know what their pattern is. The nurse needs to inspect and auscultate the abdomen as well. Let's see, part of your health education. They need to be sure to identify their own bowel patterns, which I just discussed. Daily exercise is going to help keep the gut moving, keep the bowels regular. A high fiber diet. So examples of high fiber diet are on page 706 in your book. But things like pears and apples with the skin on them, beans, nuts, legumes, raw carrots, okay? Lots of different things. and then having 8 to 10 glasses of water per day. Okay. Characteristic stool